So, welcome to tonight's event. I'll just start the slides. So there we go. Tonight's event is around the Discharge Medicine Service. Now, unlike the event we put on a couple of months ago, this is not around us delivering the service in pharmacy. This is for us to understand the hospital medicines journey from admission to discharge and how DMS fits in with that. So we're really fortunate, and I would like to say a big thank you to Calderdale Huddersfield Foundation Trust and also the Leeds Teaching Hospitals Trust, who have supported us tonight and given their time up tonight to come and talk to you about their perspective of DMS and the patient journey. So before we start, a little bit of housekeeping. So this meeting's been recorded on Zoom. We do ask that you keep your microphone muted while we're on because there's quite a lot of people and we can get echoes and background noises. If you have any questions, please do put those onto the chat. There's one of Lisa from our team at Community Pharmacy West Yorkshire is looking at the chat. We will, during the question and answer, I will then try and look at the chat as well as presenting to you if I can make that happen so that I can answer the questions in the chat. So please do ask things as you go along in the chat. We do have 2 question and answer kind of sessions within this. So if you want to actually ask your question verbally, please do raise your hand. There's a raise a hand function through Zoom, which you can access, or you can just physically raise your hand. But do bear in mind that I probably can't see you all on screen, so I might miss you if you do it with a physical wave. So we've had our sponsors, and thank you Chiesi for sponsoring this event tonight. So before I hand over to CHFT and Liz and Claire, I'd like to just do some formal introductions, go through the agenda and just start us off around DMS. So tonight, and if you're able to wave at us, that'd be great. We've got Liz Street, who's the Clinical Director of Pharmacy at CHFT. We have Claire Curry, who's Senior Technician for Clinical Services at CHFT. We have Tricia Lenk, who's the Special Clinical Pharmacist, and Keely Jones, who's the Advanced Clinical Pharmacist. So welcome to the 4 of you, and thank you again for supporting us tonight. So the agenda's there, it was on the pack, I'm not going to go through that with you. So DMS, I want to start this evening by reminding us all that DMS service is a really important service for our patients. We know that changes to medicines on discharge, can and do cause confusion about what medicines people should be taking. Going into hospital, people can decompensate really quickly, and going home can be a bit daunting for some people, and getting back into the habit of taking medicines, particularly if they've been changed. We also know that kind of the discharge between and also admission, and when people change sector from hospital to the home, is a real key point where we know that there can be errors made sometimes in the new prescriptions, that they aren't right, they haven't been amended correctly, or the old items aren't stopped when they maybe should be. So we know it's a real critical time for people from a medicine safety point of view. And we know that a lot of people have changes in the medicine. We know that older people are particularly prone to confusion and that they need that support. And we also know that 30 to 70% of patients experience unintended changes in treatment. And the DMS has been demonstrated to help all of these. So the Discharge Medicine Service is really around improving patient safety. And another thing it's also been evidenced to do is to help reduce readmission, so keep people in home when they're discharged from home. So a really positive service for the people that get referred into it. And for me, there's also a real key bit about integration. So the Discharge Medicine Service is linking us to working with hospital pharmacy, but also with general practice through the structured medication review, which we may need to onward refer patients for. So it's a real opportunity for us as community pharmacy to be recognise the work that we've been doing for quite some time with those that have been discharged and become much more integrated as part of the system. So DMS is a formal funded NHS service, started middle of February. So I thought it'd be helpful to share the kind of figures with you as to where we are with DMS referral. So I'm not going to dwell on these. You can always watch this again and to have a look at the figures if you want to. But as you can see, we have all of our trusts across West Yorkshire engaged with the service, which is great because in other areas that's not the case. And we have some referrals going through every single one of them. So we've had over 4,500 DMS referrals to West Yorkshire, but I'm sure you're sitting there as a community pharmacy thinking, well, I haven't seen many. We are looking at that, We know 88% of pharmacies have received at least one DMS referral. So when you look at the referral, the numbers, they look quite large. When you actually split them down to the fact we've got over 540 contractors, it is lower. And we accept that. And we have to realise it's early days, but we are working together to look at how we can increase the number of DMS referrals, and we'll go through that in a bit more detail later. I also want to share with you the DMS referral status. So unlike when we did it as Connect with Pharmacy, which wasn't really, we weren't funded, DMS is an essential service. And so now we must in community pharmacy accept and complete the referrals. Now, this pie chart showing the number that have been completed, accepted and referred. It's slightly skewed because we pulled this data down yesterday, and we pulled it down for yesterday. So there will have been the referrals that had been made within 72 hours still in there as referred that haven't been accepted. But the reason I'm sharing it with you, I want you to just be aware as community pharmacy contractors that and remind you that it is an essential service. It is monitored, so it's not just us that gets this data. NHS England can access the data, and the hospitals see it too. So it's really important that we have robust processes in place to make sure we pick up DMS referrals in a timely manner, that we accept them, and then we complete them so that patients can get that support. So I'm now going to go hand over to CHFT. They're going to cover the first part of the evening, and really that medicine's journey, so like patient's journey through hospital with a particular reference to medicines. So I'm going to mute myself and over to you guys.
Thanks, Ruth. Hi, everyone. Thanks very much for inviting myself and Claire along tonight. Claire's the expert, so I'm just being the spokeslady, but if there's anything technical, I'm going to refer you back to Claire, and I'm sure she can give you far more detail than me. So thanks for Claire for pulling all the slides together. So we were just going to give you a bit of an overview of the trust just to start with. Next slide, please, Ruth. Thanks. So Calderdown Huddersfield Foundation Trust, founded in 2001, achieved foundation status. So it's two sites, one in Halifax and one in Huddersfield. It's about 650 beds across both sites, and then so our team is split between the two hospitals, which we've got about 112 of us, fluctuates up and down slightly, and that's made up of pharmacists, pharmacy technicians, senior ATOs, and then some of our stores, assistant technical officers. We're very lucky at the hospital. It's a very forward-thinking digital hospital. We have a system called Cerner, which is our electronic patient records for all our prescribing and records all our drug administration. And then we have a separate system in pharmacy for supply and stock control, which is an EMIS system. They don't speak to each other at the moment, which is again one of the sort of slight issues with which we're working on to get an interface between the two. So at the moment it's a manual transcription for us when we're dispensing medicine from one system to the other. Again, it's still not quite that straightforward. We've also used other prescribing systems. So ophthalmology have one called Medisoft. We use a separate one in cancer services, which is called Varian. So again, there's multiple systems that the pharmacy team need to be familiar with to ensure we do things safely. Quite a busy department. We dispense 24,000 items a month. We outsource our outpatients dispensing to Rowlands. So we've got a pharmacy on each hospital site that deals with outpatients, and we also use other mechanisms to get medicines to patients. So we also use home care for some of our high cost drugs, subcutaneous infusions and HIV medicines. We do about 560 MDS trays per month, which I'm sure, like yourselves, are very time consuming and a bit of the bane of our lives. We complete about 90% of our discharge prescriptions within 2 hours. Well, I think it's a really good result that we've got in our clinical team, because we've got 80% of our pharmacists, we've got about 36 pharmacists, 80% of them are qualified as prescribers. Again, we're permanently looking to develop the team. So Claire's actually doing she's our first technician to be doing the clinical diploma at Bradford, which is really exciting in terms of developing our technicians. And we're just going out to advert for our first consultant pharmacist role in oncology which has actually been out for advert, and we were very excited about. We're also moving to a new hospital. We're having a new hospital built within the next 4 years over at Halifax. So again, planning ahead now to what that will mean for pharmacy, and what the hospital will look like in the future. Next slide, please, Ruth. Thanks. So in an ideal world, if things were just dreamy, the patient comes in. So this is our medical unplanned admissions. They can be referred in by the GP, or they present in our emergency department. If they need to then stay in for further treatment or observations, they get admitted and taken up to our acute admissions unit. And at that point, we have a team on the acute admissions floor, which is pharmacists and technicians, and the pharmacy technicians up there do a drug history to find out exactly what's prescribed by the GP. The pharmacist then, again, I say ideally within 24 hours, should reconcile those medicines. So that's really looking at what they've come in with, what the clinical condition is that they're in with, looking at what the EPR system to see what's prescribed, making clinical decisions on what we need to potentially stop and start depending on that condition, or if the prescriber's done it correctly. Linking in with how the patient takes medicines at home, and looking at what medicines the patient's brought in with them. And again, because as I'm sure as you know, it's not always straightforward to what is written on the GP system to how the patient actually takes them when they're in their own homes. Then if the patients are then being held in longer than that, they might go to a specialty ward, i.e. cardiology, or respiratory wards, where they're then managed by the clinical team, sort of the specialty clinical teams. Again, we hope we get them better, treating them with the right medications if needed. They're then decisions made that they're fit for discharge, and then the next step in the journey happens in that the doctors on the ward should write the prescriptions, take home medicines, and do their discharge summary. The nurses on the ward, so it's all electronic, so then the nurses on the ward get a task to then check what medicines the patient's got in their lockers. In theory, they should also check with them what they've got at home, so that we only supply them what they actually need. And it's quite different at CHFT, actually, that is a nurse-led process at our trust, which again is quite different to where I've worked before. Once the nurse has done the checks, then the pharmacist is tasked with clinically checking that everything the doctor's written is right, that we've included all the stop and start medicines, which obviously frequently change due to what the condition is the patient came in with, assuming they're all prescribed correctly in the first place. Again, sometimes we will, because with the pharmacists are prescribing pharmacists, they may make the amendments themselves, or again, if the doctors are still around and it's not after home time, they'll contact the doctors and ask them to change if there's any errors. Once we've screened it, again, very much like the process in community pharmacy, that it's dispensed and accuracy checked, and then gets sent back up to the ward. The patient then should be, if they haven't already been counselled on new medicines, at that point it's making sure that they're clear, again, in an ideal world, of what the medicines changes are, any additions, or if anything's been stopped. And then they should hopefully leave hospital, and then we should do a referral to yourselves if there's been significant changes to their meds. So again, that's our perfect world. Next slide, please. Thanks, Ruth. Unfortunately, it doesn't always go quite to plan. We struggle to get medicines reconciled in a timely way. We're getting there on the acute floor. It's less straightforward at our hospital if we get emergency admissions to surgery. We haven't got such a big team that cover that area. Sometimes we're short of staff. We, like anywhere, have leavers or staff self-isolating through the last year or so with COVID, etc. So we have to prioritise where we go and what we do when we're out there. There's always a pressure on hospital beds in terms of, whereas we'd love to make sure that we do meds reconciliation so that when the patient comes to go home, we know exactly what they should be taking and how they take it, and we can make sure everything's restarted because of the bed pressures. And it all links into pulling patients through the system. So we need to make sure patients are discharged in a timely way, so that ED doesn't get blocked with patients waiting to be admitted. And you'll all be very familiar with the 4-hour target. So sometimes there's a real pressure on us just to turn discharges around very quickly, and that can sometimes take priority over doing the meds reconciliation for new patients. We're still we're getting there in terms of our 7-day service, but it's still pretty skeletal staff on at the weekend. We've got one ward team out on either site again, which we focus on the acute admissions ward. But it's not ideal because it means if patients are admitted directly onto surgery, we potentially wouldn't necessarily see them at the weekend. And during that, with that skeletal team, we're really just responding to supply requests from those wards without without full clinical reviews and medicines reconciliation for every single new patient that they request a medicine for. Some patients get sent home before we've got to see them, and that might be they get admitted on a Friday night and have gone home on a Sunday afternoon, and we haven't seen them. So again, sometimes the information you'll see, or it'll get sent to the GP. We've not actually seen it, we've not corrected it, we've not made sure it's right. Again, we don't see every patient every day, and we don't visit every ward every day. So you can see that there may be groups of patients that can unfortunately get missed. We still have issues with timings of when discharges are written. In an ideal world, again, they should be pre-planned. They should be written ideally maybe the day before the patient's due to go home. What tends to happen is there's a ward round, they decide who's going home, who's medically fit to go. Then the junior doctors, who it tends to be their task to do the TTOs, get embarked in either they have to go off and do training. They might end up doing ward jobs like doing bloods or checking bloods, or ordering x-rays. And the process of sitting down and writing that TTO or typing it gets pushed to the back of the queue, no matter how much asking we ask. And obviously you've got a patient now who's waiting to go, they've been told they're going to go, and they're all looking at pharmacy. We're waiting for the prescription to be written because the doctor hasn't done it yet, and it can get a bit frustrating all round. And what tends to happen then is we get this glut of discharges that come down at the end of the day, and everyone's shouting for them. So again, it just gives you, it's not seamless, it's not as smooth as we'd like it to be. We sort of did a piece of work over the last 12 months at looking at some of the errors we were seeing on discharges. And again, hands up, we don't pick up all of them. So again, I'm aware that you will sometimes see these, and even with DMS, again, we welcome when you feedback if we haven't got it right ourselves. And some of it was actually due to us not training the junior doctors in the first place fully how to use the prescribing system. So again, we've rectified that this year with putting a much bigger and more comprehensive prescribing training package together for them. The patients aren't always counselled properly. Again, if we've got pharmacists and technicians up on the team, we hope that they're involved in that. Medicines can get started during a ward round, and again, I wouldn't like to say every single time that's in consultation with the patient. It should be, but it doesn't always happen. Then again, the nurse might think the doctor's explained it to the patient, and it doesn't, they're not always familiar with what the changes are. Or again, if we've stopped medicines, that's not always very clearly explained to the patient. And when there is this sort of rush then to get patients out, because ED's full, they need the beds, the patients get moved, potentially discharged, and the TTO hasn't been written, and it's certainly we've not seen it and not dispensed it. The nurse opens the patient's locker where we store their patient's own drugs, and they sometimes scoop it into a bag and off they go with it. And again, that safety check of checking, is it labelled, is it the current dose they're on, have we taken away the stopped and started? It doesn't always happen. And we're doing a piece of work now, we're sort of the other side, hopefully touch wood, of COVID, going back to basics a bit with some of our nursing teams, just to make sure we're not rushing through and making it unsafe for patients when they're discharged. In terms of then the referrals to farm outcomes, again, the team certainly recognise the benefit of the importance of what yourselves can do for those medication changes that have happened, and sort of helping our patients as they come home, you know, to reiterate some of those messages and maybe explain some of it, because again, they're given so much information, they just want to get home. I'm not sure they always take everything in, and suddenly they get home and things have changed and they can't always remember maybe exactly what was said. But the process for us is incredibly clunky at the moment. It doesn't link in with our pharmacy system or the Cerner prescribing system, which means we've got to almost download the discharge letter, change it to a PDF, then attach it and send it on through Farm Outcomes. Again, if we could get to a point of interoperability between the systems, it would make life easier, quicker, and yeah, we certainly looking at that interface work in the future. I suppose what I didn't say there, again, if patients move wards, so for instance, we've seen a lot over the last few months coming in, you know, they've ended up going to intensive care. Intensive care will potentially quite often stop a lot of medicine if the patients are on ventilators that they don't need. And again, it's that complexity then. If a junior doctor, the patient then gets better a bit, comes out to a ward, the junior doctor's then asked to discharge them. That patient might have been in for several weeks to track that journey of what got started, what should be restarted. Again, it can be challenging for patients who've been in longer, and especially if they've moved wards and been seen by different medical teams. Next slide, please. Thanks. We're aware of the problems, so it's not like we're sitting there going, oh, it's a shame we can't get it right. We're doing lots of work both with our pharmacists and technicians to look at how can we do things better. We encourage the patients or carers to bring the patient's medicines in with them, so that when we're reissuing them, if it's their own box, we can relabel it so it looks familiar to the patient. It's the same brand that they normally have, and they don't end up with multiple brands that they're coming home with. We've got the photograph here is a picture of one of our pharmacists, Hayley. So this is, rather than everything coming down to the dispensary, it's about bedside dispensing, so we can clinically check, label the medicine, and have that conversation immediately with the patient on what we're doing, what's different, and how they take that medicine. Again, we've got about 6 of these trolleys. They're not on every ward at the moment, but again, it's something we're really looking to do, and we've got them on both our acute admissions floor, where it tends to be a lot quicker turnaround of patients, to again aid that patient flow. It's so much quicker for patients to get it instantly, rather than all coming down to pharmacy and being put in a big queue where it might not be seen immediately. We are again looking at taking that nursing task away in terms of checking the locker. It's a pharmacy. It's our bread and butter to check with patients how they take their medicines at home, and looking at what they've brought in with them. Nurses are pulled every which way. We can do it better, and therefore and it will save nursing time to do other patient-centered care if we take that off them. And again, but that's extra resource we need in our team to allow us to do that across all ward areas. So again, we're doing some work, having and we've had some funding for a bigger team on our admissions areas to really sort of do all the medicines tasks and take it totally off the nurses. Appropriate supplies at discharge. Again, it's nothing more frustrating when we haven't got the ward-based teams out and about. So say at the weekend, we're relying on the nurses doing that task of what does the patient actually need. The nurse hasn't got time to do it properly, so they tell us they need everything. We're not going up there to actually check in the patient's own locker, and that's again when you end up with a patient coming in with a massive bag of drugs. They might have multiple brands of things that they've already got at home, differently from when they've had it dispensed from yourselves. So again, trying to move away from us finding out exactly what does the patient need to go home with. And again, if we can, how we'd like to improve it, if we can look at some interface between then our discharge system and with your Farm Outcomes to just streamline that process, and get the any referrals out to you more quickly. That would be dreamy. Next slide, please. Thanks. Other things we're doing. So again, we've had some funding for our acute floor, which has been fantastic. That's just been in the last 4 months. Looking at patients sometimes get discharged from a ward, again, as part of this patient flow, to move them out of the bed while they wait for transport to be sorted or their meds to be sorted, and they go to a discharge lounge. So again, looking at how can pharmacy be present in that discharge lounge to iron out any discharge medication issues. We've had some of our members of our team have worked there at the hospital a very long time, and this is a piece of work that Claire's been working on to make sure the technicians, that we're standardising how we work and how we do, to make sure we get that same quality of medications reconciliation and drug history taking across the board, and it isn't dependent on which technician you've got today or which pharmacist you've got today. Other things looking at, again, we've talked about digital, we're moving to electronic controlled drugs registers, is really exciting. Again, to help the nurses, we're looking at electronic medicines cupboards in our ED departments, which again, hopefully will help the nurses workflow to find medications a lot quicker without hunting around for keys. Whilst we're digitally forward minded, we are really slow on automation, and that's something I've been looking at, how putting a robot in the department, which again will all sort of help free up our time to do all these other things that we know we're not getting right. We've got TTOs, again, whichever hospital I've worked in, there's been an ongoing issue about TTOs is the same as sort of a discharge medication. They're always left till the end of the day by doctors, and sometimes done out of hours, and then it's the on-call teams that are doing them, and they're not familiar with the patients. So we're looking at a sort of quality improvement piece of work to how can we break that cycle and do it differently. And one of the things that's coming out of that is actually, let's take that. So we've said about taking the pod check task away from nurses. Why don't we take the prescribing and the discharge information task away from doctors? And I'm not sure if you're familiar with physicians associates that we use. We've got about 15, I think, at the organisation at the moment, which are trained to do a lot of the clinical work to support the medical team. So what we want to do is looking at physicians associate to write the discharge summary, because they can say exactly what's been wrong with the patient, having a prescribing pharmacist then to actually write the medications themselves on the discharge, and then we dispense it from a medicines trolley, and it's a job we do ourselves, and again we're taking it off waiting for other people to do it. Hopefully get it right first time and get the patients home in a more streamlined way. We are we're moving on to DMS, because obviously that's the bit that yourselves are all interested in. Again, we've embraced it for our MDSs, because we couldn't keep faxing, and it's a lot easier for us to use it than to fax. But we have struggled to really move it forward with the DMS, because it's an extra job. It's an extra job that potentially the discharges are collected. One of our assistants then spends the following morning then sitting at a monitor and processing these. But again, we'd love it to happen at the point that the patient is actually discharged. But because the teams have other priorities that are urgent, they've got nurses yelling at them to do what, well, not yelling, but everyone gets on that very well, and other priorities, it can fall down that list. So again, just to stress, it's not that we don't see the importance of it, it's just where it fits in a whole load of other priorities that we have to contend with. So again, Claire can chip in at any point if she wants to, has been really championing this for us, making sure that all our team have got access to farm outcomes, to really selling it to the pharmacy team. So again, that they can see that the benefit, it will prevent readmissions for us. And ultimately it's the patient safety, it's in the best interest of the patients that this information gets out to yourselves. We're going to target the acute floor. There's a high turnover of patients on there, and Claire's found one of our pharmacists has got community background. So again, she's absolutely out there pushing the message forward. So we're looking to focus more, to focus maybe on specific drug groups as well, rather than just leaving it open-ended, to give the team a bit of direction. Monitoring the numbers, so Claire's going to give everyone an update of how many we've done this week, again to get a bit of competitive spirit going. But I keep banging on, if we could get an interface at some point, that in itself would make it a lot less time consuming to do. Claire, have I missed? I've got the questions that Ruth shared with us. I think were raised at the last meeting. We're happy to run through those. But Claire, is there anything you think you wanted to add to what our plans are with the DMS referrals?
Yeah, so just following on from what you'd said, Liz, we were looking to kind of, in the first instance, target our acute floor and patients that come through there that get sent home fairly quickly, but they would like to kind of concentrate on certain drug areas. So they've decided anyone that's got a new inhaler or a change to their inhalers, newly started DOACs, antihypertensives, and any changes to diabetic medication, they will refer all of those now via DMS system, which is a huge step forward for us.
Fantastic, thanks. So shall I run through, Ruth, are you happy, just some of those questions that I think were raised at the, do you want me to start with those, or?
Well, let's see, is there anything in the chat? Because I struggle to see the chat and share screen. So is there anything in the chat that's come up, or anybody wants to raise their hand to ask a question? If the raise hand function, you'll have to do at the bottom of your screen through your reaction key. Well, we're waiting to see if some of those come in, Liz. So one of the questions we had, and I'll ask you the question, you can answer it really, was that pharmacies sometimes find, and we've had reports really from across West Yorkshire, that it's sometimes several days after the patient's been discharged until they actually get the information from the pharmacy. Now, it might not just be around your hospital, they could come across from West Yorkshire, but why is sometimes delay in after discharge it coming through to the pharmacy? Because sometimes we've already seen the patient or missed the opportunity to kind of really engage them from the very beginning with the DMS service.
So again, we've got a bit of a Monday to Friday plan with, I mean, we are changing it, so we're trying to get the ward-based teams to do it themselves now, which again is what Claire's working on. Certainly for the MDSs, it was probably the following morning, would it be, Claire, to say that I used to see Zoe with a pile on the desk as she sat working.
Yeah, we try to do them within 24 hours, wherever possible.
So again, if there are, again, I'll say it if anyone has specific incidences where things aren't working out and they've had a load of dross sent from us, or, you know, is a massive delay, please contact me and email me, because it will help us to look into those queries as well. So we can find out, you know, we want this to work. So again, let me know. That's
really helpful. Thanks, Liz. And I think it's helpful to understand that I'm just looking away. There can be delays, as you say, if you're working Monday to Friday, but you do your best you can. And I think most are within the time frame of 24 hours. It's just the occasional one. We had a question in the chat. What is DOAC? What does DOAC stand for? Because obviously in community pharmacy, we tend to refer things as drug names. So if you're just able to go through what you mean by DOAC and what would be included in that.
So that's your rivaroxabans, your apixabans. Oh, you're testing me now. You can tell because I'm so clinically rusty.
Sorry. Well, I asked you not to answer the question myself. Yeah, that's fine. So yeah, so there's direct oral anticoagulants. So they're not, well, so if you started warfarin, it could be that too. But those kind of drugs, which I think are really key to get people to take those regularly, because they are, you know, they're going to stop them potentially usually having another stroke, aren't they? Another question that we were asked actually when I've talked to contractors about this is, with regards to medicines reconciliation, I've had some feedback that sometimes community pharmacists get phone calls from the hospital asking them for information about what drugs people are on. And the question was, why do you ask community pharmacists that question sometimes? Because you should have, well, we assume, we don't know, do you have access to the summary care record? And of course you do then have the general practice to ask who do make the prescribing. So are you able to give us, shed some light on that one, Liz?
Yeah, and again, to us, it wouldn't be very convenient to have to phone you. It's a lot easier for us to go straight to a screen that we access with our smart cards, and we can literally print off then. So all I can assume is there were certainly in our area, there were a couple of GP practices who we hadn't got community view for. And again, am I right, Claire? And also some patients don't have their information shared on that. So all I can think of, if it was either of those, but our routine process, because it's quicker, easier, you know, otherwise we've got to find a phone. Well, bear in mind we're on a ward and everyone's nabbing the ward phone. I that's not the way we normally do it. If we've done it, I'm assuming it's because either we can't access the system, or if there's a specific query. I don't know, I was trying to think if patients are getting, I don't know, supervised methadone or something we wanted to check specifically. But again, Claire, what are the tips?
I was just about to say that. So if it's something that only a community pharmacy would know, like a supervised dose of something, then we would try and contact a community pharmacy in that instance. So we wouldn't want, as an example, someone to have 2 doses of methadone that day. So we would like to try and get in touch with someone and say, they've had that with us, please don't give that out.
And again, I suppose the other thing is with Vena links or MDSs, isn't it? If there's queries on them, when do they last have them? When
Yeah,
are they
things like what do you put in the dose set box? Is there anything that you leave out that we should know about? Do they get anything else sort of separately that maybe the patient's not told us?
Thank you. I've had a quick look at the chats now. We had a request, can we not have the direct contact number for the discharge team? I can try answering this one to start off with, and then you can add to it. But I know that in community pharmacy, when you get your DMS referral, there is a telephone on there, a number for you to contact, and that's the most appropriate number. So there is a number already, so you don't have to go through switchboard to go to the discharge team, and that number should be able to help you and triage all those calls. And that might be something which we cover on the next section with leads. There's another question around, do you prescribe inhalers by brand? I suppose you can only answer that for CHFT, but do you prescribe your inhalers by brand?
Claire, what are we putting on the discharge?
Some will say both, in honesty, but the Trimbo is prescribed as Trimbo, Clenil is prescribed as Clenil. In the yeah, kind of both really, and both names would appear on the TTO. Okay,
that's really helpful. Thank you both. I think that's answered all the questions that I've been able to see, and if I've missed any, Lisa will let me know when we do the next question and answer session. That was really helpful. Thank you. A real insight into the reality for you, the pathway, but also some of your pressures. So thank you both very much for that. So now going to move on to LTHT. I'm going to stop sharing because they're actually going to share their own slides, and I'm going to hand over to you, Tricia.
Hello, thank you. So let's hope this all works out. Can you see the presentation properly?
I can, yes.
Yes, okay, great. So we were thinking quite a lot about how we can gain the most from today, and I really hope that by us sharing some of our issues, and I really hope that, you know, everyone who's listening in can give us some feedback on this as well, because we really want to hear what the issues are at your end as well. So let's hope this is a two-way stream. So to start with, I just want to say we are actually not using the web-based platform, we're using the integrated version. So our system is actually PPM Plus, and on PPM Plus we've got some documents that we utilise to actually utilise the Connect with Pharmacy discharge referral. So hopefully with the integrated version now being tested and we know it's working, you will see some more referrals in the community as well. So we were thinking about some of the issues we were kind of seeing coming in terms of calls from the community, from GPs, and we were trying to divide some of the issues up. So when we do our discharges, a bit similar to what was already mentioned, our electronic system requires us to do a drug history. And from that point onwards, we have an inpatient drug chart and a discharge chart. And if things aren't quite right on our drug history, things can definitely go a bit pear-shaped from there. So if we don't document at the very beginning that the patient is taking, let's say, modified release metformin rather than just the metformin, this would pull through to the inpatient chart and possibly to discharge. So we've definitely had some calls into MI, was it an intentional change? And a lot of it, when we look back at it, was, no, actually, we've done the drug history wrong. Another issue that we found was when the discharges are getting done, So if you think about, you know, our hospitals being pretty much open 24/7, discharges happen throughout the day. We're working really hard at the moment at getting discharges done before 3 o'clock. But that's our ideal vision, and we all know that whilst in some cases we can really make it happen and make it work for patients, there will always be discharges happening out of hours that we can't necessarily predict. And as everyone will be aware, there's a lot of pressure on beds at the moment. Discharges happen throughout the day. But the people that do the discharges later in the day are often the doctors, the nursing team, the pharmacists who've never met these patients. So it can be really tricky to get a discharge with great quality when they haven't necessarily been involved in the discharge and in the patient care. Who's processing the discharge? So at different sides of the hospital, you've got different specialities, and later in the evening, you might have an oncology pharmacist, a pediatric pharmacist dealing with a geriatric discharge, and different people will look at discharges in different ways. I know for sure that when I'm on a late night and I see a pediatric oncology EDAN, I'm dreading it, and I would love to do the best I can to make every change clear on that EDAN to not just the parents, but also to the GP that will look at it, but can be very difficult. Communication on discharges can be confusing. We've definitely had calls from pharmacies, from GPs, from patients, where the clinical information, so the information about the patient stay in hospital, doesn't quite reflect what was actually visible on the medicines list. So it might read that medicines have been stopped because the patient had poor renal function or a renal hit, an AKI, and the medicines appear on the discharge list. So definitely something around communication that needs to be improved. And another theme we've identified was IT, and our system is eMeds, and it can be great, and sometimes it's just not quite doing what we would like it to do. So we started to look into some of the themes, and I thought some of these discharges can be incredibly complex. And I thought I'd share with you one of the discharges I've actually recently done. So this is the discharge journey of one discharge. We started it on one day, and 2 days later we finished it. This wasn't an overly complex discharge. The patient came in for cardiology reasons, and there kept being amendments to the discharge. So things kept being bounced back and forth between the doctors changing things, the pharmacist validating the EDAN again, so the discharge letter, then it going back to pharmacy to being dispensed, then another change. And that's where sometimes things can just go wrong. We can have the best intention to make sure every change is very clearly documented, but then things happen on a weekend or late at night, and things can go a bit pear-shaped from there. So the way we do the discharge, and it might be quite interesting to hear how it works, is the doctors would start writing the discharge letter by putting the clinical information in, and they write down, patient was admitted with acute chest pain on acute exacerbation, or I don't know, dizziness or a fall. So that would be your clinical presentation, and the doctors would put down what happened during the admission. Once they're quite happy that that's all completed, they'll add all the medicines on, and sometimes that's pharmacists doing it for convenience. Sometimes it's advanced nurse practitioners, so it's not just doctors doing it. And then we will validate it. So the pharmacist will validate the EDAN, and we will make sure that all the changes are reconciled properly. That would be in an ideal world. Sometimes things don't appear, but I'll go into more detail on that. Once we've validated it, either we will speak to the patient about assigning the sources, and I think my colleagues were already saying it's very similar. Somebody will check if the medicines are on the ward or not. We will supply what is required. It will be sent to pharmacy where it will be dispensed. They will then send it up to the ward, and the nurses will do a final check. So at the final check that the nurses will do, they should check that all the medicines are labelled up, that the medicines that they will put in that discharge bag are all for that patient as per the discharge letter. And there's definitely some issues, and I'm not going to repeat what my colleagues have already said, but those issues happen everywhere depending on who's sorting out that final step. Sometimes medicines end up in a bag that shouldn't be there. So that's kind of the flow. Sorry.
There's been a question put in chat and I'm interrupting, sorry.
Yeah.
So
Yeah.
what's an EDAN?
Oh, an EDAN is just like a TTO. It's just the electronic discharge letter. So just another word for it, but it's just the same as a TTO. So we are starting to think a bit more about where's the patient in this discharge process. A lot of the clinical information is already available to the GPs because it's all saved on an electronic system that they can usually see themselves. The way the discharge is written is not necessarily patient friendly, so we're not putting all that information on there for the patient a lot of the time. And at LTHD, we're now looking into completely redoing the way we're doing discharge letters. And it will be interesting to see what happens from there. The project group is working very hard and getting lots of views and opinions from different clinical groups to see how we can make those discharges clearer, easier to write, and cut down on time. The follow-ups on there can be a bit misleading. So sometimes the doctors will put the follow-ups on there and then the pharmacy department will put a comment on there, which can sometimes contradict things. Can be very frustrating, I'm sure, for those who are reading at the receiving end, because the intention is always to make things clearer, but sometimes I think when I look back at discharges, I'm not sure we really achieved that. But our biggest bugbear will always be from the pharmacist's point of view to make sure that all medicines changes are clear, easy to understand, and that doesn't always happen. So I try to break down the kind of challenges we are having at the Trust, and this comes mainly from calls we received in medicines information, who are dealing with all the kind of calls we have around discharges from GPs, from community pharmacies, from patients. So I hope that this kind of answers some of your questions for all those working in community pharmacies, but please write your questions down as I go along, and I hope that we can answer some of them, because I think this would be really good to hear what you've got to say as well here, because I'd like to get answers for all our problems. So one of our biggest challenges is what we call the multi-line orders. So on the discharge tablets, I've put a copy from an EDAN from a discharge TTO, an example of an insulin prescription. So those multi-line orders are basically, our system is telling us they can see that the dose that we've put on meds on admission and now is on the discharge tab, which is just a different screen, could be the same, but it might not be. So that's where it can get really confusing for us and on discharge and for the GPs, because unless we clarify whether there was a change or not, we get a lot of calls around that. And it can be very confusing for patients who are on, let's say, insulin, and maybe they get some help with their insulin doses. Has this dose changed? Is it continued from admission? So really, we need to do some serious work on that at our end to make sure we get that right every single time. It should be part of our discharge reconciliation process. We should always make sure that we highlight if there was a change or not. But in practice, we know it doesn't always get done. And I've got some examples that many of you might remember from practice now. So we have that issue sometimes with pregabalin and gabapentin. If we've done a dose change, sometimes we haven't clarified that. And we definitely get calls through to say, this gabapentin dose has increased. Was that intentional or not? The same applies to furosemide, bumetanide. Medicines where they might have frequent dosing, so twice a day, 3 times a day dosing, and that's also why we see it on insulin. So we have some issues around that, and that's the way our system eMeds presents that line, that prescription. But that's definitely something we know we need to work on. We know it causes a lot of confusion, and we're fully aware of it. And we appreciate every time somebody calls, it's for a clinical indication to make sure we get that one right. Discrepancies in general can be very confusing. So when we put medicines onto the meds on admission side, so our drug history side, we need to make sure that we actually action something there. We either need to continue it, stop it, or withhold it to discharge. So it's very tricky sometimes when patients come in acutely unwell to make decision on certain medicines. We actively decide sometimes to not actually do something with this drug until patients have improved. If their renal function isn't great, if they have got very low blood pressure, we might choose to not actually prescribe some of the medication we know they've been taking prior to admission. When we don't actually do something with that drug on discharge though, it doesn't appear anywhere on the EDAM. So we definitely get calls from chemists again, from GPs to say, what happened to this drug? It's not anywhere on the discharge, and it's not written down that it was stopped or it needs restarting. And that's because nobody actioned anything. So we've definitely had issues with things like methotrexate. Patient was acutely unwell, was on antibiotics, and we've just not prescribed it on the admission. Somebody should have made a clear action plan to say, restart in 2 weeks once the antibiotics have been completed and the patient's feeling better. That needs to be highlighted somewhere. Similarly, if patients come in on cocodamol, we don't tend to prescribe cocodamol. Usually we tend to go for paracetamol and dihydrocodeine if necessary, or codeine, but we don't tend to prescribe the combination preparation. So that sometimes just ends up not being prescribed on discharge. When we ask patients on admissions about creams and ointments and things they don't necessarily bother too much about when they're an inpatient, they don't necessarily get prescribed. Again, we get calls about, has this been stopped? My favourite example still is sildenafil. Patients don't tend to require sildenafil during the inpatient stay. That doesn't mean we've stopped it, we just don't tend to bother with it. So I think sometimes it's just an awareness of what kind of issues the people who will do the discharge medicine service referrals feel are an issue, and where we can maybe help to educate on some of the issues where we just will not actually make a decision, and in the community things can be restarted. Similarly, formulary changes such as patient came in on Cal-CD and we've changed it to AdCal. A lot of things I think will require some education at both ends to just say, actually, it's just a formulary change, and patients can continue to take that when they go back into the community. Another thing that we've noticed is when patients come in and they may have been seen in clinics or they've made that decision themselves, they may not take medicines prescribed as what we can see on the SDR. So just today I had a lady who's got metformin once a day prescribed on an inpatient chart. On the SDR it says twice a day, and she's actually not taking it at all. And that's because she had really bad GI upset, so she's been suffering with that for a while. And actually when she discussed it with the diabetes team that look after her in the community, they advised to stop it. And so that's where we sometimes see some discrepancies happening. And again, we need to learn from that. We need to make sure that at discharge we make a clear plan and explain why we've stopped it, or why things might look a bit different to the summary care record. IT related issues, so that's EMEDS. I try to give you an example of when things start to look a bit weird and can look a bit confusing. So things like warfarin is our biggest bugbear. The way we prescribe warfarin when patients come in on the admission side, we don't tend to pull it through to discharge because of the way we have to prescribe it as an inpatient. So anyone who's ever received an EDAM with warfarin on it from LTHT will have probably seen the ceased and new, and we will have said, this is not ceased and this is continued and not newly started. It can be very confusing, but we do try and clarify it where we can. But on this example, this particular example, we've got the loperamide capsules ceased and loperamide dispersible tablets started. I mean, I'd argue, I'm not quite sure why the change was made. Was it really necessary to change it all back to the medicines on admission to make sure everything is reconciled properly? That's when we end up with that really long list again of all the changes we make. It's quite a lengthy process. which is why sometimes in the community you'll see not actually changed. It's time saving for us. It would add an additional 15 minutes to every discharge we process sometimes. Weekly prescriptions such as buprenorphine patches or alendronic acid, sometimes it shows as changed because they may have missed the first dose because they were admitted on the day when it was due for a change or when the administration was due. Again, I think we should make sure that we clarify at our end whether it can go back to the usual days or why we've changed it. I think it definitely causes some confusion. But we've discussed it as a team. We've had a really lengthy meeting about it, and we are aware of it, and we're trying to improve it. So hopefully whoever gets the discharge referrals going forward has a much nicer looking discharge letter in front of them. Compliance aids. So I've given you a bit of an example here of how we prescribe them. So we prescribe it as a dummy drug, what we call it. So it's not a real drug, but it will show as a prescription on the list. And I've also shown you what it would look like on our system in terms of how we add the form. So we've got an admission form and a discharge form. When patients come in on a compliance aid, we will have to put on an admission form to notify the community pharmacy that the patient is an inpatient. If we fail to do so, you will not receive that information that the patient is now with us. So that's why sometimes I think we've had some calls to say, oh, we never had notification that the patient is an inpatient. A lot of the time it's just human error. And the same applies to the discharge form. The discharge form is what we will utilise going forward for the discharge medicine service. One of the reasons why we've not had a ton of referrals from us is because we had to check that our IT system is still working for this. Because with the Connect with Pharmacy form prior, we had lots of reasons for why we can refer patients. And with everything now being the discharge medicine service, we had to make sure our IT system is still robust enough to actually be able to make sure we can do the referrals. So whenever we looked into specific incidences where community pharmacies have said, we've not received this referral, 8 out of 10 times it was because somebody hasn't filled in that form. So it's human error. Unfortunately, it happens sometimes, especially over the weekends when maybe we weren't able to contact the community pharmacy and we weren't quite able to confirm the patient is still receiving a compliance aid because that information might be a bit out of date. So if anybody has questions around compliance aids or what happens here, please put the question down and we'll try to get to the bottom of it. So what can we do better going forward? So I think I've already tried to highlight some of the things we've definitely unpicked and that we at LTHT are quite keen to work on and to improve on, because I think we do understand that this is a two-way stream. We understand that for community pharmacists, this might be potentially quite overwhelming to review some of these patients because, you know, they can be really complex. Some of the medicines changes have been done by specialists in their field. And if we don't clearly reconcile why the changes were made, I can only imagine it must be very confusing to look at some of these discharges. So we need to help each other here, really. So I've tried to pick an example of a discharge where I thought this was done really well and very clear, and I hope you'll agree with me. So in the pharmacy advice box, somebody clearly made a plan for some of these medicines and what needs to be done going forward. The changes were clearly discussed with the patient prior, so all these things to the patient also make sense. So the patient was a cardiology patient, as you can imagine here from some of the terminology. So DAPT, dual antiplatelet therapy, which is usually your aspirin and ticagrelor or your aspirin and clopidogrel, depending on the patient, is to continue for 12 months. So very clear plan here as to how long this should be continued for. Monitor the use and ease. So the patient was at the time prescribed some potassium replacement, and this was only to be continued for 3 days. So the plan is for the GP to follow up on use and ease. Monitor LFTs, they were deranged. The statin was on hold, which is something we would routinely do. And clear plan, this is not to stop. This is to be restarted once the LFT, so the liver function, has improved. In all cardiology patients, we try and up-titrate medicines because that's what the evidence base suggests. So we're trying to up-titrate the ramipril, the bisoprolol, or whatever the patient is prescribed. And as part of the prescription, it usually already tells you that, but again, clear plan, monitor the BP, and continue to increase as tolerated. And the discharge letter actually had everything reconciled really nicely. So a very clear plan as to why medicines were stopped or started, what the plan is going forward. So for the antibiotic course, very clear plan as to when to finish it, very clear plan for the DAPT, for the clopidogrel, for the medicines to be restarted. You'll see a lot of the COVID vaccine now, and a clear plan why we just ceased it. 2 vaccines were already given. It's part of our standard admission plan now to check with patients if they require their second vaccine as an inpatient, so that's why it's there. Short-term plan for the pain relief, clear plan for the furosemide based on the echo. So we're really trying here to explain why we've done what we've done. Stopping a GTN spray, you'll see quite a lot when patients had certain procedures done. If patients had vessels opened up that were blocked prior, that may have caused shortening of breath and chest pain. Everything's good again. They don't need it anymore. Very clear plan for all these medicines. And wherever there wasn't a clear plan, they tried to reconcile it. So again, the lansoprazole was stopped but restarted. For the pharmacist to make sure that looks as if it's to be continued would have been another 10 steps. So they've just tried to reconcile it here properly. And I hope you'll all agree with me that this looks quite nice, quite tidy, how you would like a discharge to be done. And I think that's what we're aiming for. So I thank you for your attention, and I really hope we can have some good discussions about this. And I'll leave my screen open maybe for a bit longer in case I need to go back to a slide. What do you think?
Okay, thank you, Trish. That was really, really helpful. There's been a few questions in the chat, so
Yeah.
and I can see some have been answered. Somebody asked, and it's been answered, but does the discharge note go to the GP as well? As many times they haven't received, so we send them a copy. So I've had this feedback too, that GPs are saying, well, you're getting the discharge before we are. Is that the case? And should we be sharing a copy, or should they getting finding their own copy on their own system?
Yeah, so I give you some examples here. So the discharge will be sent to the GP once the nurses have released the discharge letter on the system. So when you go back to the slide, sorry, this may look a bit confusing. So when we go back to this lovely flow diagram, let's call it. So the last step will be, we have released the medicines from our pharmacist side of things. So the medicines have been dispensed. We're happy with what was dispensed. It gets sent up to the ward. The nurses will do their final check. And when they press complete, they will print a copy of that discharge letter for the patient. And as soon as they press complete, it triggers something in our system to actually send that letter to the GP. And that will also trigger the referral to the discharge medicine service. What sometimes happens is the nurse will complete the discharge, but the patient isn't actually going home. So that's when we see issues happening. And sometimes you see there's a second version of a discharge. And that's because we had to reopen the admission and make changes. So when the plan is for the patient to go home tomorrow, and then they had a fall on the ward, and then they stay another 2 weeks, that's when we see problems happening in terms of discharges and how they get sent. But as soon as we've completed the discharge on the ward, the copy will automatically send to the GP. And ever so often there will be an IT glitch, but that should be rare.
Thank you. I'm just reading a comment. Unchanged medicine section is very important, so that when such medicines are not mentioned again, we know that this is continuous. That's just helpful. The question is, LTHT policy now to send the admin notification at the same time a discharge notification? Again, we're having some feedback that they're arriving at the same time, which doesn't seem to make sense. We need to be really clear from the DMS point of view. Actually, admission notification isn't mentioned within the DMS. It's something which we set up locally within West Yorkshire to be helpful, so you knew that the person was in hospital. So it is an optional part of DMS. But yeah, any reason why you think they might be coming very close to each other?
If we've just realised that patient is a compliance aid patient. So sometimes what we've had is we check the drug history with a patient, and the patient will say, I don't have a compliance aid. But actually the patient has a compliance aid but is a bit confused, and actually it's the wife that looks after the medicines or a relative. So that happens. It doesn't happen often. We've had a very interesting conversation recently, and we were discussing summary care records and information we would love to see on there, and it included a very clear information as to, is the patient on a compliance aid, because we used to see a lot of the sevens. 7 dose units were dispensed for certain items, and that already triggered something to say, oh, that patient's on a compliance aid. But when patients have the 28 dose units prescribed, a lot of the time that falls through. So when they come to the discharge and we realise actually they've got a compliance aid, that might be one of the reasons. And sometimes patients are in and out very quickly. Again, they'd be close to each other. But usually what should happen, as soon as a patient comes in and we do the drug history, you should get the admission notification as part of that, and the referral for discharge medicine service, and that the patient leaves the hospital should be at discharge.
That's really helpful to understand, thank you. A comment here, but I think there's probably a follow-up. Sometimes hospital abbreviations are not familiar with community pharmacists, so not necessarily clear. Could you use full terminology? And I suppose the answer on an EDAN is probably not, but actually I think that's really some helpful feedback. If we have seen an abbreviation, where can we go where we can find out what these things reliably mean? But are they consistent across hospital trusts? Because we don't use the same term. We could start throwing 3-letter acronyms at you that make no sense to you. So it's about understanding the language jointly.
Yeah, definitely. And I think we've had some really good conversations over making things a bit more patient friendly. We ideally have a discharge letter that a patient can read, and it doesn't look alienating. So again, very good feedback. I appreciate that, to actually use language that's easily understandable to anyone reading this discharge. It'd be interesting to hear what kind of terminology maybe is unfamiliar, because I think maybe we are starting to be a bit blind to a lot of it because we're so used to using it, as we just heard with the DOAC and the DAPT. So I do wonder sometimes if we do events like this a bit more regularly, not regularly, then maybe it'd be really good to maybe come up with some things that worked really well, things where we can see actually this works. And yeah, in terms of abbreviations, it'd be really helpful if maybe we could, I know you do newsletters, is that correct usually?
It is, yeah. So if anybody's got anything recurrently that comes up, they don't know what it means, I think it'd be helpful to get some, the list could be very long, couldn't it? But
yeah, I think that's the idea, isn't it, that we learn from each other here. And I think it'd be really helpful to see where we can support you as well, because what we've discussed is that the more confusing we are at our end, the more calls we end up with in medicines information, because we're not clear. So if we can help make things clearer, then that'd be great. Maybe there's something we can continue to collaborate on in terms of the newsletter. Maybe there can be some feedback from your end as to what people find challenging. Maybe there's something we can do here.
Thank you. I'm slightly mindful of time because we were due to finish at past, but there seems lots of questions. So I'm going to continue if people are able to keep joining us. We've got a question: why does discharge have the same drug on different lines or repeated? Is that I don't know if that's been explained in your slides, but is that because sometimes you have to cease and start a drug just because the way your system works, and that actually to do it another way would be very time consuming? Is that correct?
So if I'm correct, I'm having the example here of the lansoprazole. Is that kind of what people are referring to?
I assume so, yeah.
No, Ruth, can I jump in, please?
Oh, please do. Yes, please.
Yes, please.
No, so what it is because you don't use drug strengths, you use doses.
Yes.
So you might get frusemide 80 milligrams.
Yes.
And then further down you get frusemide 40s. And then on the discharge it says frusemide 40s stopped. And it actually just means the lunchtime dose, not necessarily the tablets, because we only know them as 40 milligram tablets.
Yes, thank you, David. Really appreciate that. So yes, so what happens is, and now we're going into the terminology, I'd love to share a drug chart with you to show you the complexity of this. So let's say a patient gets admitted in the middle of the night and the doctor will prescribe all the medicines. What we should be doing is what you can see on the screen, which says lansoprazole without a strength, because if we make changes throughout the admission, the changes would show as changed. But if we prescribe lansoprazole 15 and now we're giving 30 or vice versa, actually, let's give the example of 30 because you wouldn't have a 30 lansoprazole capsule, would you? So we would stop it and prescribe it differently. Now, I'm a pharmacist prescriber, and I would probably say 9 out of 10 times I will go through the effort and pull back medicines from the admission to discharge tab back and forth to make it look right. Now, a pharmacist who's not a prescriber may not choose to do this. And this is probably what happened here. There may have been a reason why this patient was switched to an IV infusion. We don't know. Maybe the patient was acutely unwell after they've had their heart attack and ended up on the coronary care unit for a little while, and they gave IV omeprazole. The doctor stopped the lansoprazole capsules, and now we restarted it. So sometimes it's just something really silly as that, and really we should pull it back so it shows as continued.
Thank you. Got a question from Sifat around, can we summarise the DMS points? So tonight's not really around the community pharmacy element of DMS service. So all the information is on PSNC, and we've got some on our website too. Sifat, if you're still stuck, email us at info@cpwy.org and we'll help you. Akbar asked, what do we have to do with admission notifications on pharma outcomes? Nothing on pharma outcomes. It's just so you're aware the person's been admitted to hospital, so you're aware to pause dispensing and you know there may be changes coming. You don't record it on pharma outcomes because it's not part of the official DMS service. David from LTHFT has also put on that if you are stuck with any context, so you're looking at it, you've got an acronym in front of you, no idea what it means, the contact number on the discharge, you can ask them the question and they certainly will help with that. Felix, I can see you have your hand up. Felix, can I hand over to you to ask your question?
Yes, thank you. Well done. We have heard from 2 trusts this evening, the different things they do. And from what we receive usually from Bradford and Cogdale, I've seen that it seems each trust is developing the method of delivering the DMS to us. And yet we have a standard way by which we follow. So it means the program has been designed and put more, I won't say put more pressure on us at the pharmacy end, and yet more flexibility at the hospital end. I probably can understand the multidisciplinary situation involved in it, but I think if a program, something like this is coming up, a situation whereby at another level, things can be harmonized, and we know that all hospitals follow the same thing, so that when we receive it, we know exactly what we are doing. I put a message across before about if we know if all medicines received are listed, and we know that on the standard, if nothing is changed, only the things that are altered that we look out for later. If nothing is changed, you don't have to start ringing the hospital. Is scarcity still there? Is XY still there? But what, so if we have that situation whereby there can be a standard practice across board, it will be very helpful for this program.
Tricia, can I ask you to stop sharing because I've got a couple more slides to finish up, and actually Felix, I might be able to answer a little bit of what you're asking with what we're doing next. So let me just share my screen again. So flip through the slides. Can somebody give me a wave? They can see my slides moving. I'll not do mine in order. DMS is a really important service for the system, and actually this isn't something which we set up and any of us are walking away from. You know, it improves patient safety and reduces readmissions. So we have a West Yorkshire pharmacy leadership group, which is attended by trusts, by the Community Pharmacy of West Yorkshire, by CCGs, by representatives from across the system that work in pharmacy. And one of the priorities we've picked up is DMS because we know it really helps patients. So we are, I'm in the process of trying to set up a DMS group across West Yorkshire so we can have a look at how we do DMS to make sure we are as consistent as possible. Now, each hospital has a different system and will have different processes. And so there will always be some variability, which I know is challenging if you're on a border. And as you say, Felix, you get some from Bradford and some from Calderdale. However, we are looking at working together so we can share things amongst each other and try and make it as consistent as possible. There is also a toolkit out there for hospitals too, and that tries to get the consistency. So I can't promise we're going to get rid of all the variation, Felix, because we aren't, but we are working together to look at DMS to make sure that as a system across West Yorkshire, we look to improve and increase the number of referrals. So I hope that gives you some assurance that we are all in this to improve, and hopefully we'll get some more consistency. And as it beds in and we get more referrals, I think we'll get to understand how they work better. DMS is an important service for us at community pharmacy. It uses our clinical skills. Hurrah, at last. We're being funded for the work that we are undertaking, and it really helps increase our integration. So this is part of our 5-year contractual framework development, and I think it's really important. I'm really pleased to see you here tonight. It's really important we support DMS. I hope tonight's given you a bit of an insight that, and thank you to Tricia and to the rest of, and to CHFT as well for giving up tonight, because it just goes to show that you are dedicated to DMS, to making things as smooth as possible so we can all help patients together. So we're at the start of a journey. You know me, I'm a believer. We don't start a service and walk away. We have to keep supporting you and delivering that service. So hopefully this is a start, as Tricia says, of maybe us having more events, in a few months, just so we can keep learning and keep that communication channel open. So mindful of time, is there any final questions at all? The toolkit for all the DMS information is on the PSNC website, so I'm just putting in the chat. Can we send it? Actually, we don't need to. It's all available on PSNC under the DMS. So without further ado, I'm going to give you a little bit of your evening back. I'm sorry we've overrun, but I think it's been very helpful to hear. So thank you very much to everybody who's come tonight to give your evening up to listen to us. Thank you to the Community Pharmacy West Yorkshire team for all the work you've put in getting this event set up and making it work. And thank you to our speakers tonight, to Tricia, to Claire, and to Liz. And good evening, everybody. Take care.